Morning, good afternoon, and good evening. Thank you for joining the Wilson Center's Maternal Health Initiative, along with U.S. Agency for International Development's Momentum, Country and Global Leadership, or MCGL, for a panel discussion titled No Progress Without Quality, Country-Led Strategies to Improve Maternal, Newborn, Child, and Adolescent Health and Family Planning Outcomes. There's a lot to unpack there, and I really look forward to engaging with an esteemed panel of global experts to learn more on country-led initiatives that are improving the health and well-being of women and their families. I'm Sarah Barnes, and I will be your moderator today. I direct the Maternal Health Initiative, or MHI, at the Woodrow Wilson International Center for Scholars in Washington, D.C., but I'm joining you today from Bern, Switzerland. For those of you who are unfamiliar, the Wilson Center is a critical source of nonpartisan foreign policy research and analyses where we work to tackle global issues through independent research, open and honest dialogue, and actionable ideas. At the Maternal Health Initiative, we focus on a multitude of global issues, including maternal and child health, gender equity, and sexual and reproductive health and rights, as well as the importance of health systems and policies to better the lives of women and children. Today's event is the second in a series between the Maternal Health Initiative and MCGL, meant to elevate country voices in the global dialogue on maternal, newborn, and child health and family planning. Our panel today will tackle the necessity of quality care, particularly in the time of COVID-19, in efforts to improve maternal and child health and family planning outcomes. I'd like to take a moment before we start to thank USAID's Momentum, Country and Global Leadership, or MCGL, for making this event possible and for all the behind-the-scenes support in designing this event. The Maternal Health Initiative is thrilled to be engaged in this series with MCGL, particularly given the focus around the deep experience and expertise and promising practices of partners in low and middle income countries, whose voices have often been underrepresented in global conversations. MCGL, as many of you likely know, work with partners, including but not limited to ministries of health, the private sector, civil society, and faith-based organizations, as well as youth-led organizations, to collectively build effective and sustainable improvements in the health of mothers and children. And a huge focus of these collective efforts is quality. In low resource settings, poor quality care is a bigger barrier to reducing mortality than lack of access to care. And high quality health systems could prevent 1 million newborn deaths and half of all maternal deaths. Yet, amid an ongoing pandemic, it's more difficult than ever for stretched health systems to provide safe, quality healthcare. So what have countries learned as they work to provide quality health services during the COVID-19 pandemic? This question is at the crux of our discussion today. We will focus on country-driven efforts to achieve high quality care and strategies to support quality improvement efforts at every level of the health system, including national, subnational, and service delivery. To kick things off today, we will hear from two quality experts from USAID and WHO, the World Health Organization, and then we'll spend the majority of our time with experts working in and from South Africa, India, Sierra Leone, and Ghana. You'll hear about quality, youth-friendly family planning and reproductive health services and care in India, quality of care for women and children of all ages in Sierra Leone, and improving quality of WASH, which is water supply, sanitation, and hygiene, in 5 countries with a deep dive on Ghana. Panelists will address important themes, including measurement, governance and leadership, capacity building for quality improvement, and accountability. Before we begin our discussion, I would like to thank all of our speakers for taking the time to be with us today and to share your expertise. I know we are spanning many, many time zones, and I really appreciate your time and the effort you've put in preparing for today. Also, a huge thank you to the MHI and AV teams here at the Wilson Center, and also to our audience for taking the time to sit with us today. In order to make the most out of this discussion, we ask for an active audience, and we really would encourage those watching online to submit questions for our panelists. You can submit your questions to mhi@wilsoncenter.org. And near the end of our program, we will pose those questions to our panel. We have almost 800 RSVPs for today's discussion, so I know quality of care is something that people are really interested in talking about. So please send us your questions, and in that way we can ensure that we're addressing the aspects of quality of care that matter most to you. Again, you can send those questions to mhi@wilsoncenter.org. You can also follow the discussion on Twitter @Wilson_MHI using the hashtags quality of care and MH dialogue. Okay, so we have a packed 90 minutes. So without further ado, I'd like to introduce the first of our two opening speakers, Dr. Patricia Jodrey. Dr. Jodrey is the Child Health Team Lead at the Child Health and Immunization Division, Office of Maternal, Child Health and Nutrition at the Bureau of Global Health of USAID in Washington, D.C. She brings more than 35 years of experience in research and community health, focused on child health, management of undernourished children, and strengthening systems for pharmaceutical management. Dr. Jodrey, along with colleagues Lily Kack and Debbie Ambruster, co-chairs an internal cross-cutting working group on quality of care, and is also part of a technical working group on quality systems, and is one of the co-chairs of the subgroup on quality of care of the Child Health Task Force, which is a coalition of partners, multilaterals, and implementers aiming to revitalize the interest in child health. A fabulous choice to kick off our discussion on quality of care. Welcome, Patricia, the floor is yours.
Thank you, Sarah, for inviting me to speak at the opening of this important event. It's a pleasure to be here. As you mentioned, despite the notable increases in access and coverage of health services, evidence from the Lancet Commission work shows that in low and middle income countries, the expansion of health coverage or access to care has not always been accompanied by mortality reductions. However, that analysis also showed that when countries have progressed in improving the quality of their health systems, the survival rate tends to improve. This highlights the importance and immediate priority of improving health system quality. USAID has supported quality of care for almost 40 years, and even in the 1980s, the assessments of service delivery made it evident that more deaths were due to poor quality care than due to lack of access to health services. Since then, the subsequent flagship projects have addressed several components of quality assurance and quality improvement. Among those, the Quality Assurance Project in its many iterations marked a clear transition from focusing only on compliance with the standards to the implementation of continuous quality improvement cycles to address gaps. The ASSIST project also demonstrated how best to use quality improvement approaches at facility and community level. Its legacy is a collection of case studies that focus not only on what to do, but on how to implement the whole process of quality improvement, the particular challenges, and the benefits that doing so entails. As a large proportion of people resort to seeking care in the private sector, our implementing partners are supporting governments and private sector providers to ensure that these services adhere to the minimum quality standards and adopt a quality improvement culture. Projects like SHOPS Plus and MCSP have demonstrated how best to engage the private sector and developed approaches to improve some aspects of their service delivery. But we still have a long way to go in working with the private sector. Within USAID, the Maternal and Child Health and Nutrition Office works closely with the Office of Health Systems to achieve a holistic approach to quality, expanding on both the range of factors required to achieve quality, as well as going beyond clinical services to a system-wide approach. The momentum awards that work in different country contexts and in the public and private sector are currently leading the way to ensure quality care in those complex settings. USAID has closely collaborated with WHO in the development of the framework for quality care for women, newborn, and children, and in the quality of care standards for facility-based care of mother and newborn, pediatric and young adolescent, and small and or sick newborns. Our aim is to ensure that countries are fully engaged and lead in the application of these standards, measure their progress, monitor the quality of services, and conduct improvement processes in a systematic manner. In particular, we're making efforts to ensure that the standards related to experience of care, including respectful care, become part of the core body of work adopted by countries. In summary, USAID considers quality of care a priority for our work. Our approaches use a range of interrelated intervention areas that also include institutionalizing continuous quality improvement and health worker performance, strengthening pharmaceutical management systems, including the regulatory capacities and pharmacy practices, supporting governance mechanisms for quality to ensure policies, partnerships, and regulatory compliance in public and private sector, developing and incorporating digital tools and standards to strengthen the integration of quality improvement approaches within supportive supervision, and strengthening infection prevention and control policies and processes, and the use of continuous quality improvement processes by infection control committees to sustainably improve IPC programs, so much needed in this COVID pandemic era. Thanks for the time you have given me. Back to you, Sarah. Thank you.
Thank you. Thank you very much, Dr. Jodri, for kicking us off today. I look forward to talking with you more and learning more about the work of USAID at the end of our event. So next up, to help us set the stage on quality of care efforts is Dr. Blerger Malichi. Dr. Malichi is the team lead on policies, strategies, and planning in the Department of Maternal, Newborn, Child, Adolescent Health, and Aging at the World Health Organization in Geneva, and manages the WHO-based Secretariat of the Network for Improving Quality of Care for Maternal, Newborn, Child Health. She has worked for the past 25 years in the areas of health policy and systems development and program implementation, with a special interest in health systems analyses, management, and measurement in quality of care. Trained as a medical doctor, Dr. Malichi holds a PhD in health systems management development and a master's degree in health management policy and planning. Wow, thank you so much, Dr. Malichi, for being here today, and the floor is yours.
Thank you very much, Sarah. Colleagues, thank you for inviting today me to speak on behalf of WHO, but also on behalf of the Network for Improving Quality of Care for Maternal, Newborn, and Child Health on key issues around quality of care, but also in terms of evidence and development, but also in terms of country implementation and a way forward. Next slide, please. The Sustainable Development Goals have confirmed that global commitment to achieving universal health coverage by 2013 is not enough without quality of care. The renewed focus on the SDGs and the acknowledgement that effective coverage of essential health services and financial protection doesn't ensure that services are delivered with quality is a very important acknowledgement. As a result, in the past 5 years, we as a global community have been working together to strive towards universal health coverage with quality. As Dr. Tedros, the Director General of my organization, WHO, has said, without quality, there is no UHC. Next slide, please. But what it is quality of care? Without going into many details, I wanted to pull out the definition of WHO on quality of care. Quality of care is the extent to which healthcare services provided to individuals and patient populations improve desired health outcomes. There are a number of parameters or criteria that define quality of care. So quality is a composite of many events that happen. However, those that are the most critical, for which we have put a lot of attention in the past, as Dr. Jodri said, 40 years, have been efficiency, effectiveness, safety, timeliness, and in the last 5 years, we have focused on integration, equity, and people-centeredness, which are criteria that have been built to respond not only to the SDGs agenda, but to the overall development and health agenda. Next slide, please. So what is the problem and what are some of the solutions? Why we are here today? Next slide, please. In the last 3 decades, the world health and the global health has seen massive improvements in terms of life expectancy, but also in terms of survival. In 2018, the Lancet Commission for High Quality Health Systems undertook an analysis to see where was the overall health impact in today's world in terms of health. And what the report finds and states is quite interesting. In today's world, mortality due to poor quality healthcare is very important. 8.6 billion people in low and middle income countries die from causes amenable to healthcare. So we have solutions, but quality of care, it's not there. So poor quality, and this is not due to non-utilization, it's simple poor quality of care. 5 million or 58% are attributable to receipt of poor quality of healthcare. 1.9 million deaths occur in South Asia, with the greatest mortality due to use of poor quality healthcare. And poor quality health systems are a greater impediment to improvement of population health in poor rather than in rich countries. Next slide, please. As I would like to focus more on maternal and newborn health, I try to bring up some of the evidence that this report and others highlight in relation to maternal and newborn health. We have all witnessed the wonderful progress made during the era of MDGs, and we all are aware about the SDG Sustainable Development Goals targets for maternal and newborn health as part of the overall health target. So we do know that the world has made substantial progress in maternal, newborn, and child survival since 1990s. Globally, the number of neonatal deaths has declined from 5 million in 1990 to 2.4 million in 2019. However, this decline in neonatal mortality from 90s to 2019 has been slower than that of post-neonatal and under 5 mortality. So that is another issue we need to look at that. However, at this moment, I'd like to go back to that issue of quality. So in addition to newborn mortality, we have seen that maternal mortality has declined. So maternal health has improved. The global estimates in the year 2017 indicated there were 295,000 maternal deaths. However, the global maternal mortality ratio in 2017 was estimated at 211 maternal deaths per 100,000 live births, which is very high. And if we compare that with the SDG target, that is 70 per 100,000 live births by 2030, with a margin or interval for countries that being adjusted based on their level of development, we can see that today's mortality is not yet on track. And if we start to study a bit more or further why these women and babies are dying, we can see that neonatal deaths, 58% of neonatal deaths are due to poor quality care, not lack of access, not lack of interventions, but quality of care. So babies are getting interventions, they're accessing them, but quality is not there. And half of maternal deaths is due to poor quality care, which brings us to a very important agenda around not only access, but rights and quality, what happens there. Next slide, please. 3 seminal reports have helped us to build the evidence and to understand better the situation. All those reports coincidentally came out in 2018, which gave us a very good background to strengthen the arguments of why should we focus on quality of care. Next slide, please. Before the 3 reports and in preparation for these reports, but not only, but in preparation to developing the agenda around the SDG implementation, WHO and partners, and some of those partners are today around this plenary session, and there are some speakers, did sit down and started to unpack this quality agenda. So for the first time in 2016, WHO issued what it is called the Quality of Care Framework that started with Quality of Care Standard for Maternal and Newborn Health, was pursued by the Pediatric Care Standards, and then later on Small and Sick Newborn Standards. That framework and standards are based on an idea that quality is not only about the criteria, but it is about provision and experience of care. The attention that has been given usually to quality of care in the past decades has been driven by inputs. With this quality of care framework, we did change the focus by moving not only on the inputs, but also on the experience that is underpinned by the strength of the health system. Next slide, please. So with these few elements on mind, I would like to share with you the work that 10 countries and over 20 partners, among whom USAID with a multitude of implementing partners from JPIGO, and I'd say in the past it's almost a 10 years collaboration, so it doesn't sit only with today's MCGL collaborative, but also with past collaboratives such as MCPSC and the ASIS programs have worked and contributed to develop together with WHO and partners. Next slide, please. In 2016, a series of consultations by WHO involving government representatives, UN agencies, and implementation and funding partners discussed what was required to build systems that support the delivery of quality of care in an effective, scalable, and sustainable way, and assist countries to achieve their SDGs. The consultation noted, or that consultation at the time noted, that most quality improvement efforts were still project-based. They did not always have initial funding that did not survive after the end of the promise of the project, and the promise at the end very little in terms of scaling up and sustainability. The consultation agreed that more learning was needed to understand how to implement and sustain quality of care, and that efforts should be put towards building a facilitated global learning network on quality of care. So with this in mind, in February 2017, 10 countries, Bangladesh, Cote d'Ivoire, Ethiopia, Ghana, India, Kenya, Malawi, Nigeria, Sierra Leone, Tanzania, and Uganda, all, I would say, partners in implementation supported with USAID at the country level, together with WHO, UNICEF, and FPA, and the myriad of professional associations and other organizations, established a network for improving quality of care for maternal, newborn, and child health, or the network. The vision of the network was that every pregnant woman and newborn should receive quality of care, and the goal was to reduce by 50%, maternal and newborn mortality in participating health facilities. Next slide, please. To achieve this goal and vision, the countries in the network who are in the driving seat, along with their partners, articulated 4 strategic objectives: set of leadership, action, learning, and accountability. I'll go a bit more in depth as I move into the next slide. Could you please, next slide? So to operationalize this type of strategic vision and to move from theory into the practice, the countries of the network, along with the partners, developed what we call the country implementation approach. And it's a country implementation approach that is clearly based on national policies and strategies, but also with operationalization at the national, subnational level, going down to the facility and community level. All this is underpinned by health systems. One major requirement of the country implementation was that country leadership, government leadership, but at the same time, the criteria of establishing systems and structures required to implement quality. So by leaving quality as a task of everyone and not having a recognized structure at the national, subnational level, at the implementation level that looks after quality and quality improvement, it is very difficult to make any change. With this idea in mind, that part of implementation and dissemination, which you see in the middle of the image, supported by 5 interrelated functions of on-site support for quality improvement, the learning system, the measurement, community engagement and stakeholders engagement, and the program management is very important if we would like to see any improvements in quality. And finally, we cannot have a learning health system and a learning system based on quality if you don't have a measurement system in place that allows you to measure not only the progress made for impact and outcome, but also on the processes, practices, and everything that determines our quality improvement. Next slide, please. I'll take a few more minutes in describing what has happened over the years with the network countries and what is their progress. I'm sorry I cannot put the data for 2021, which is being now consulted and finalized with countries. However, I'm happy to report that as you move into this dashboard towards 2021 and more towards those strategic objectives of accountability and learning, they become greener than what they were until end of 2020, despite the pandemic and its impact in systems and practices. So in line with the strategic objectives, implementation at country level began with a focus on leadership. Soon it moved into the action, which is based on the district learning model, so subnational level, with a lot of support in terms of moving towards not only quality improvement processes, but also all the system development and building processes, and then underpinned by this agenda of learning and accountability that at core has the data. So what have we learned in the past 4.5 years of implementation across the 10 countries, which is useful for other countries that want to strengthen their system to deliver quality of care in a sustainable and scalable way? So the network has been successful in keeping quality of care at the top of countries' national health agenda. The ability of the network to stay flexible and respond to country needs has been fundamental to this success. National quality of care policies and strategies and related MNCH roadmap have successfully been developed and updated, which has led to governments dedicating domestic funding to operationalize quality of care support structures. However, so despite all this initial investment, more funding is needed to scale up implementation of quality of care and quality improvement capacity building. National technical or working groups that coordinate government and partners' quality of care for MNCH are operational within the coordination national structures, which is very important for the alignment, but also for sustainability. However, this coordination did not always lead to partners changing their quality of care technical support objective. And finally, the leadership structures for quality of care have been built in all the countries, We have to underline that at times tensions can arise between the new quality of care structures and existing MNCH programs or other programs in general, due to absence of clarity in roles and responsibilities, but also due to the feeling that programs need to take the leadership into the implementation while they feel the pressure from another additional, let's say, layer of bureaucracy in terms of quality of care. So that is the overall progress on leadership. But what has happened with the action? WHO, important for the action part was the institutionalization and adaptation of WHO standards, quality of care standards that I already introduced earlier. All the network countries have adapted the standards and the packages of interventions that support their implementation. In the learning districts this has benefited from the use of existing quality improvement methods supported by coaches trained as part of previous quality improvement programs. And scaling up the experience from learning districts within network countries requires anyway continuous technical assistance and support. This is something I'd like to underline because countries will have to strengthen their implementation and they need the partner support for that part. On the measurement side, which is quite a running theme across all the implementation, I have to say that the common set of indicators was successfully discussed and agreed with countries up front. Most of those indicators are in the health information system, but many of them are not included. So that collection and reporting of quality of care information and measurements does show the ability of a country to deal with information in general, but also in particular on quality of care. Progress in documenting and sharing this data varies across countries. Health information systems in many countries continue to face structural and operational deficiencies, which undermines this part of the ability of a country to demonstrate their information. And then the analysis of this information still needs to be linked to the implementation to drive improvement and impact. So districts and facilities do need capacity building. That's a major area for capacity building, and impact evaluations are needed. I'd like to underline that this is a work that has been developed across all partners and countries. WHO, along with JPIGO and other partners, do co-lead what is called the quality of care measurement working group that brings together all the scientists, implementers to discuss, but also to decide on what are the next steps. Finally, on the learning and accountability, progress is made.
Dr. Malichi, I'm sorry to interrupt, but just maybe one more slide and wrap up because you are at time. Thank you.
This is important, as without the learning and accountability systems, we cannot move forward. Last slide, please. As we move forward, it's important to share the key lessons learned. It takes a whole health system to improve quality of care. So you do need support systems, financial governance structures, and systems levels. Government leadership and long-term commitment is a prerequisite. Quality of care requires dedicated and sustained investments and partnership. We do need to recognize that health systems operate in different contexts, which impact the pace of quality of care implementation. You do need investing in early and intentionally in the development of the information system and quality of care data. We need quality improvement capabilities, which are necessary as a function across all the system. And then it will be very important that throughout this agenda of implementation, we do keep in mind the communities, the users, hence their engagement in defining what quality is, but also in making sure that we do achieve quality is very important. Thank you very much.
Thank you so much, Dr. Malichi. And there's a lot to unpack there, so I'm looking forward. Also, as I mentioned, Dr. Jodri and Dr. Malichi will be here throughout the duration of the event. So towards the end, when we do the audience Q&A, if you have questions particularly for them, please send them along. Again, it's mhi@wilsoncenter.org if you have a question for any of our panelists. And so now we will move on to the next part of our event today, which is our panel presentations. And so we have 4 panelists today, and I'm going to introduce each of them and then cue them off one by one to give their presentations. And the dreadful part of being the moderator is also I'm the timekeeper. So I will jump in, keep your chat open. I'll also chat you, but I will jump in if you're going over time. And as I've said, I will try to come back to you if there's some things you do not get to say in these beginning presentations. So first we have Dr. Zoya Ali Rizvi, who is the Deputy Commissioner of the Adolescent Health Division at the Ministry of Health and Family Welfare with the Government of India. She works on the promotive and preventive healthcare of school children and adolescents in schools, health facilities, and communities. Welcome. Next, we have Matron Margaret T.T. Manna, who is a midwife specialist with over 30 years of midwifery experience at clinical, academic, and public health institutions. Matron Manna is currently the program manager for the National Quality Management Program for Reproductive, Maternal, Newborn, Child, and Adolescent Health Directorate at the Ministry of Health and Sanitation. She is also currently an associate lecturer at the College of Medicine and Allied Health Science in Sierra Leone. Welcome. And next we have Maureen Shaballala, who is a public health practitioner with over 20 years of experience in healthcare, and her key areas of expertise are improvement science and health system strengthening. She is currently a senior project director at the Institute for Healthcare Improvement, where she leads and manages their improvement projects in the Southern African region. Welcome. And our fourth panelist is Mavis Gomcore, who is a biostatistician and a deputy health information officer at the Christian Health Association of Ghana. She specializes in qualitative and quantitative methodologies and tools for clinical and public health research to improve the quality of care delivered to patients. So as I promised at the beginning of this event, we have an incredible group of panelists, and we'll be talking about a varied list of thematic topics, as well as looking at several different regions. So to kick us off, we will start with Dr. Zoya.
Hi, good evening, everybody. I will be talking about improving accessibility, affordability, and quality youth-friendly family planning and reproductive health care in India. This is about, you all must be knowing India is the second most populous country in the world. And it is very easily said that every fifth person you meet in the world is an Indian, and every fifth Indian you meet is an adolescent. So that's a huge population which we are talking about. Next slide, please. If you look at the population, just I mentioned, is we are, the adolescent population of India is 253 million, and it is counting, it's increasing, and we're looking at about 300 million by the year 2050. So that's a huge population, and any health intervention is going to lead to much, much improvement in the health outcomes for the whole country. What we have seen that any intervention for health has shown a decline in early marriages for the teenage population, as well as teenage pregnancy has gone down. It has gone down from 27 to 23% early marriage, and teenage pregnancy has gone from 8% to 6.8%. This is over the last 5 to 6 years. This is based on what we call the National Family Health Survey. And the good thing about this is that these two indicators is shown in majority of the states, the decline in early marriage as well as the decline in teenage pregnancy. So our SRH component is working quite well. Regarding another reproductive health issue is the access to safe menstrual hygiene management, which in our country in majority of states has shown a good increase from 55%. We have increased to 77% of 15 to 24-year-old young women have access to safe menstrual hygiene products. Another thing which you also look at is that besides these other SRH issue is the unmet need for contraception, which sadly continues to be about 22%. So our young people, 22% of them do not have access to safe contraception within the government network. Next slide, please. So to cover these various components, we inaugurated and are implementing a program which is called the National Adolescent Health Program, and in the local language it is called Rashtriya Kishore Swasthya Karyakram, which is a kind of a mouthful. It covers the 6 thematic areas which were decided after a countrywide international coordination system was put in place, and these 6 thematic areas were shortlisted as improving sexual reproductive health, prevention of substance abuse, addressing non-communicable illnesses, addressing enhancing mental health interventions, and preventing injuries and violence, including gender-based violence. So what the 3 components of what accessibility, affordability, and quality has been ensured by ensuring that the service provision to this adolescent and youth age group is there at the basic at all the government health institutions, so that every adolescent is empowered to reach out and ask for help, support, commodities, or any services within the government health systems. And in fact, all our components are looking at both the determinants of health as well as the consequences of the 6 thematic areas. Next slide. So our components are basically 3 prongs. So we have facility-based approach, the school-based approach, and the community-based approach. Just to quickly give you a brief background, the facility-based approach is is in the government health systems at the smallest of health level, which is at the population of 5,000, up to the health institution, which is at the population of more than 100,000. So all these facilities have what we call the adolescent-friendly health clinics, which are manned by trained medical officers, auxiliary nurse midwives, and counselors. And these people provide free of cost services, counseling, commodities, and services for any visiting adolescent and youth. And they also do outreach activities within the schools and community. And besides, if we move to the school-based, we already have programs which are ensuring access to safe menstrual hygiene products to girls who are attending school, as well as provision of iron folic acid tablets to girls and boys who are attending school. This all is free of cost, as well as annual health screening. So every child attending government and government-aided schools is screened for 32 pre-decided conditions, which include deficiency, diseases, developmental delay, and diseases. So all that is covered by the mobile health team visiting schools annually. And now lastly, we have also inaugurated what we call the health and wellness program within schools, which is a coordinated programs of health and education working together to improve the health of school-going children and adolescents. And finally, the last intervention which we have for this age group is the community-based, which is very critical because India still has out-of-school adolescent boys and girls. For them, we have what we call the peer educator program, in which the peers are selected, young boys and girls are selected and trained over 6 days, and they form small groups, and they talk about the various health issues, which are broadly covering the 6 thematic areas which I mentioned. Besides this, what we have is adolescent-friendly clubs also. These are again at the smallest population, at the population of 5,000, in which the auxiliary nurse midwife talks and discusses the adolescent issues with the adolescents in their own area. And of course, the provision of IFA tablets and of the sanitary napkin continues in the community by using another department intervention, in which there is a field level care provider who is trained, and then she is the person who distributes napkins and IFA to the adolescent in her area who are out of school. And finally, the most important thing in the community which we are looking at is what we call the Adolescent Health and Wellness Day. Next slide, I just discussed it. It's really very important for us because, next slide. So this is one intervention which is supposed to cover the adolescent per se and the various stakeholders who are involved in adolescent health, be it the parents, the teachers, the field level health workers, the what we call the village elders, all of them. So these are quarterly health activities which take part in the villages, in the schools, in community centers, and these involve, there's a huge amount of health awareness which is happening, and as well as there is activities which are plays, skits happen, there is speeches, we have small movie shows, we have quiz competitions, we also have painting, displays, and we also have talks by the medical officers and doctors who are visiting this. So it becomes like a community event or a school-based event. So this is something which has really grown in the recent days, last 1 year, even when COVID was there, we had schools were locked down, there was no school, no colleges, but these activities continued to be held, whether it was for improving COVID awareness or for keeping the children and the families safe. And we, in fact, just to share a number, we had about 146,000 adolescent health days were celebrated over the last 1 year. But just a word of caution is that this is still a very new event. We do want to find out what is the quality of the services which is being provided so that we can further improve it. So we are always open for improvement because this is an age group which is like so dynamic, keeps improving. You keep having new issues this age group is facing. So we are looking at further improvement in all the service provision for this wonderfully dynamic and exciting age group in our country. Next slide. And I would just like to end that for our country, adolescent age group is a unique window of opportunity. And we look and we thank all our supporters who are helping us implement this program, on whether it is WHO, whether it's the UN partners, or even the non-governmental organizations which are supporting our states in implementing all the interventions which are looking to improve access to health, make it more affordable, make it more quality oriented for everybody. Thank you so much.
Thank you, Dr. Zoya. That was really incredible. And I would love to just follow up. I have a few questions. I mean, I think the Adolescent Health and Wellness Day sounds really interesting, and I'm sure others will have questions on that later on. But one of the things you mentioned on one of the slides was the school health and wellness programs. Can you speak just a little bit more to what that is? And is it different than regular like health checkups being done in many governments?
Oh, thank you, Farah. That's a wonderful question. And that the basis of this program, School Health and Wellness Program, is the partnership and the ownership of the health of growing children between Health Ministry and the Ministry of Education. So within this program, what we do is that we train 2 teachers per school on 11 themes, and these themes range from emotional well-being, safe use of internet, prevention of injuries and violence in school, healthy lifestyle, nutrition, sanitation. So there are vast variety, and teachers are trained to on these topics, and then they interact with the school children, because we realize that every child spends about 7 to 8 hours in school. So that's a very positive time in which once the teachers have the knowledge, so they can interact and make it kind of joyful activity in school. So it's not like an exam-based thing, but it's more of activity-oriented. So children learn these things while they are playing, while they're interacting. So they have a lot of this ownership has started. In fact, this program is barely not even 2 years old, but even during COVID, we managed to train a lot of teachers. In fact, now we have trained more than 150,000 teachers have been trained over the last 7 to 8 months. Schools are reopening, and once the schools have reopened, the sessions within schools are starting. So we have started getting, some reports are ticking down, and they're really very, I think, positive. So we need to strengthen this partnership so that health of a child is responsibility of the teacher, the education, as well as the health service provider.
Wow, thank you. That's wonderful. Thank you so much. Next, we will move on to Matron Manna. The floor is yours. If you need to unmute.
Good afternoon, everyone. I bring you greetings from the Ministry of Health and Sanitation and the National Quality Management Program. Next slide, please. So this is Sierra Leone. I'm just giving you some key statistics. Why, in the first place, quality of care. Sierra Leone, over the years, partners and UN agencies have invested so much in maternal and newborn mortality reduction and morbidity as well. But over the years, we did not see much. So the government declared free healthcare because cost was identified as one of the key barriers to reduction of maternal and newborn health. So that report, we delivered like free healthcare is now over 10 years, but we have not been able to see much decline in our health statistics, as you can see. Another assessment was done, and quality of care was identified as one of the key contributing factors to the poor status of women and children in the country. Next slide, please. So then we advocated and lobbied for political will. So that with strong political commitment, Sierra Leone's president has to request from WHO for Sierra Leone to be among the countries in the QED network, and Sierra Leone joined in 2017. But we had like political turmoil, and the elections were ongoing. When we had the next government in place, they established the National Quality Management Program in 2019, and that led to development of the policy and the roadmap. And we have 25 learning facilities, thanks to WHO's and other UN partners and partners like PIH and QUAM, that led to the establishment of 25 learning facilities. Next slide, please. Well, with the strong partnership, coordination, and collaboration, this slide is actually showing where we were and where are we. So staying very focused as a nation, we will definitely be able to at least have the maternal and newborn mortality and morbidity as a country. Next slide, please. This strong advocacy and political will, and also initial work in 25 learning facilities, we have been able to scale up quality of care in additional 53 facilities with support from MCGL and other partners in the country. Principally, WHO also is still continuing to support us. That has led to the appointment of 36 salary and dedicated QOC and patient safety officers at district and facility level. We have also been able to mainstream QOC in partner and donor programs. Then we have created a strong coordination and technical working group. Next slide, please. And QOC is now mainstream in national agenda. So that in terms of sustaining our actions, we've been able to develop a draft implementation package that we have been piloting to address the core mortality and morbidity for maternal and newborn facilities. We've been able to strengthen the MDSR. Now we are going to have MPDSR. We have been able to plan and roll out small and sick newborn standards. We have established 16 SCBUs as a country. We have provided guidelines, protocol, and we have an currently ongoing integrated sexual reproductive health and rights and EMOC assessment. Next slide, please. Then we've established mortality reviews. In terms of measuring and demonstrating QOC agenda, we have been able to develop common core QOC indicators, and that has been created within a dashboard at the DHIS2. Then we have previously we used to have challenges in the MDSR data, but using the QOC lens, we have been able to verify, and the report has been published already that is available. Then we are doing data quality, ongoing data quality, and periodic supervision and coaching using our quality of care coaches and others in the DHMT. Next slide, please. So next slide, please. This is just to show you trends, at least for a year, on our maternal mortality in health facilities in the country at district level. So you can see where we started, and the implementation of the QOC, we have been able, and we know currently where we stand. Next slide, please. This also with specifically is the momentum implementation sites. We have been able to look at anemia in ANC as well as malnutrition screening during a sick child visit as a facility. So you will see where we started, and now with QOC, the trend, the graph has started going up. So if we continue in this trajectory, we'll be able at least to achieve our national strategic goals for quality of care. Next slide, please. Now, this slide is actually giving you a subset of priority activities for 2022. The district learning sessions are ongoing currently. We are going to embark on QI refresher trainings, and we will train more because we have few challenges that we have learned for. Then we are now going to have like the blended virtual support that we give our QI teams and coaches. Then we have to establish a 4-day national learning session. So at this point, I just gave a snapshot of what Sierra Leone has continued doing. So I want to thank you for your attention.
Thank you. Thank you very much. And I just want to say to all of our listeners, we will make these presentations available after the event, so you can really look through the graphs and the statistics. Just a quick question to follow up before we move on to the next presentation. You mentioned recently appointing the first ever quality improvement and safety officers in Sierra Leone. Congratulations, that's very exciting. And can you briefly describe that process? The process by which these new positions were created and the opportunities and maybe the challenges you foresee in the district level efforts towards quality of care?
Thank you very much. Since we started the implementation of quality of care at district and facility level, we actually learned from some lessons that we learned. We realized in the first place that it was becoming more challenging on the national team to do on-site coaching and supervision. Then additionally, the staff that we trained initially as the QOC coaches at district and facility level, there was a huge attrition. At any time you go, after every 3 months you go down, you'll find out somebody has been sent or have been redeployed. Then we also realized that there was oversaturation of staff. Some facilities were understaffed, and whereas other facilities had huge staff, so they were not actually doing much. And that same facility, you have seen even the background of the QOC, there was maldistribution of professional cadre in the country. They are more skewed to urban areas and live in the rural areas, not provided for. So with these levels, we started discussing among ourselves, what is it that we want? What do we want to achieve now that we have the QOC roadmap and the policy as a country? And we have at least milestones that we are looking at, the M&E framework. So we started engaging national level and for us to have more political will and commitment. So we started engaging senior managers as well as partners to let them know that these are some of the challenges that we have started envisaging. So we developed a draft terms of reference. When we ask the question, what do we want? Whom do we want? How long do we want them? And which task or role do we expect them to do? So we developed that terms of reference that was shared among the key governance structure. That is the technical working group nationally. We hear all partners and members, program managers and directors. So they gave their concurrence, and that one was moved to the steering committee, and the chief medical officer and the deputy ministers of health were engaged. So they saw the need, because we cannot invest, and when we go, somebody is not there, and there was nobody that was looking at the QOC activities. Then we have seen there is an increase in QOC activities. We started the child audit, and we started the near miss and clinical meetings on a daily basis. But we are not having records. There was nobody to do minutes, or even like you have a one-stop shop where you go and find. So this actually brought in this initiative for us to have at least a salary. And you are all aware that Sierra Leone has gone through several challenges. We have the civil conflict that led to migration of key and professional health workers. Then we have like the mudslide and other things that came. The Ebola came, where we lost key human resource. So we need to have somebody to start tracking on QOC activities at district, and so that led to this initiative. And we cannot use volunteers, because Sierra Leone has also huge human resource that we are volunteering. So we thought, if we need to have our work and somebody to look at it, we need to have somebody that is salaried. That person at least has something to show for. So that led to this appointment. And thanks to my partners, thanks to the Ministry of Health for willingly accepting us to have those. So they were appointed, is like a cycle. We share the draft TOR for the medical officers, the superintendents, as well as the district medical officers and district health sisters to look at it, so that they see which areas we need to have. So that one was verified, finalized. Then the chief medical officer has to write a letter to all facilities and all districts for them to appoint somebody, and we share the TOR. So based on that, nominees started coming in, and we did an initial training. We have done the initial training with them. Then we realized the MDSR data, we have collected like 5 years. We have huge discrepancy. We have the IDSR system that is also capturing data on maternal deaths. But the three, one, including the DHIS2, they were not speaking. So we needed these people, and we brought on board the M&A officers in those districts and facilities, and we trained them together. Now we have encouraged the districts and the medical superintendents to at least provide a sitting space for them. And the sitting space, we have to pair them up with the M&Es, so that these ones will be able to translate or clarify using the ICD classification of maternal death and also child death. So now this is how we were able to have them, and currently they are enforced. So in terms of opportunities, I think
Margaret, I'm gonna stop you now. Sorry, we can come back to the opportunities. I want to make sure we get to Maureen and Mavis's presentation, and then I will come back. I just made a note of it. But thank you. I mean, it sounds like such an incredible process, but thank you very much. Really impressive. Next, we're going to go to Maureen Shaballala. There you go, Maureen. Thank you very much. The floor is yours.
Thank you, Sarah. Thank you. I will be presenting on improving quality of watch services in 5 countries during the COVID pandemic. Next slide, please. So the objective was to rapidly improve watch services in the 5 countries in all the health facilities that we engaged with, which was 152 healthcare facilities in Bangladesh, India, Sierra Leone, Ghana, and Uganda. And the timeline for the project was September 2020 to September 2021. Of course, countries had different timelines. As you can see, Uganda is still busy with their work plan, which they'll finish in March 2022. However, for us to be able to improve these services, we had to think of technical approaches. So one was to make sure that we can strengthen the infection prevention readiness in the healthcare facilities. And secondly, we can also do QI capability for the district coaches, as well as look at 4 priority measures that we could focus on, which was on hand washing, PPE, COVID triage, and also compliance of cleaning protocols. Next slide, please. So the support that we provided was providing QI coach training for the district coaches. We trained 108 of them, and also offering frontline staff who are doing IPC. 196 of those did that in 5 sessions, and these were done for all the countries. And also there was a virtual QI data review meeting. Remember, we were in the middle of the COVID stage, and we were using other platforms as well, like moderated WhatsApp, to make sure that there's continuous peer learning. They are sharing materials and ideas on the WhatsApp and Google site for just-in-time learning. And the district coaches also did in-person support for facilities that were doing poorly. Next slide, please. So from the facilities that I've shared, the 152, they were distributed differently. We had 96 public facilities, 39 faith-based facilities, 12 private facilities, and 5 that were non-profit facilities. Next slide, please. So from this particular work, I'll be now just giving aggregate data for all the countries, but just an example, Mavis will come in with the Ghana story. So if you look at improvement infection prevention readiness scores, which had a 100-point scale, we saw an average score increase together with median increase for the overall of the 152 facilities from 50 to 72. However, we had Ghana who saw the smallest change, but they began with a bigger or a higher baseline. And then Bangladesh was the country that saw a huge highest median and both average score increase. Next slide, please. And also we saw improved availability of basic wash services like water, sanitation, hygiene, waste management, and environmental cleaning. If you look below the slide, there are percentages in terms of the improvement that we saw. The gray color is where we didn't have any services. The light green is where we had limited services. And the dark green is where we had basic services. Next slide, please. So for provider adherence with hand washing and also PPP standards or PPC usage, we saw a large difference performance around hand washing, and our prediction was that this was like, they must have been probably observer bias or fear. It was in the peak of COVID, so you can see how they perform. But around PP usage, we saw some positive trend across the countries. We saw movement from 44% to kind of 69% overall performance. Next slide, please. So having given this overview and for continuity, how do we improve as countries and sustain wash service improvements? So there is need for ongoing leadership engagement at all levels to be able to institutionalize QI, and also infrastructure and local structures needs to be in place to promote improvement or to enable improvement. This could be basic resources, having functional QI teams, because if we have basic resources, then facility will be ready to do these changes, and also we'll be able to have QI processes that are functional, QI teams that are working well, and also there'll be supervision. Ongoing interaction is key when you think about QI improvement. There has to be ongoing training, mentorship, coaching of QI teams, including new people that are joining the IPC team. They need to know what's going on. So interaction is key. Also, we have to develop aims that are aligned to what we want to change, and they should be measurable. So data usage is key to quality improvement, and also change ideas that we'll be testing are key, because not every change can bring improvement. It's good to introduce a change, but not all change brings in improvement. So rapid improvement cycles are key to this work. Documentation is key. We need to share the best practices that we are seeing. If we cannot document other places, other countries, other local settings will not be able to. However, if we have facilities that are ready, there's proper readiness of facilities, and we have proper QI processes, then all the time there is greater, faster improvement that we can see. So before I hand over to Mavis to share the Ghana story, I'll leave you with this quote. Knowing is not enough, we must apply. Willing is not enough, we must do. Thank you.
Thank you so much, Maureen. Just quickly before we move to Mavis, I just wanted to kind of follow up. Thank you so much for sharing your expertise on quality improvement, capacity of health managers and health workers. It's really, really fascinating. And I'm curious, at the height of the first wave of the COVID pandemic, you and your team provided virtual support, exclusively virtual support across the 5 countries to improve WASH services. Can you quickly just describe what that looked like?
Wonderful. So the key thing is we had huge leadership support from the ministries and the local partners that were working in country. That was an enabling factor for us that facilitated what we wanted to do. They were able to coordinate efforts within the country to lead the work locally and provide the support that was required. And also remember, because we're doing virtual support, we also had multiple other platforms that we were using to make sure that activities are happening. We know, like in Africa, including the other countries, Bangladesh and wherever, India, and wherever we were, use of WhatsApp, it's very common. So we also had a moderated WhatsApp application that teams were using to share their stories, take pictures of what is happening in the facilities, or to ask the leads questions. So that was very key. And also we use Zoom for the trainings and Google Site for sharing of materials as well. And also they were able to access data systems, for example, M-Water, where they're able to see how they are performing. But having said that, we also had a country, as I said, leadership support like Bangladesh, which come forward to say, we would love to do virtual, but for our setting, we've tried it before and it has not worked. So we would prefer to do an in-person, following all the COVID protocols, and we know how we do it. And I must say that thumbs up to the senior leaders as well for making that available and appreciating the efforts of Bangladesh to do it on site, but being able to do all that. Another point was that for us to have it functional, the countries provided the exact times that they needed for the training sessions to happen. Mostly it was in the afternoon, and we did provide materials electronically, so that worked for most people. But also we have learned to say virtual platform, Sarah, is doable, although previously we never thought we could use this particular platform the way we are using it now. And also the facilities had resources that were provided, so they were able to be in groups following protocol and be able to do all the lessons, and so they were able to provide data. The only addition that I can make as I'm thinking through what we did, we also had lessons that we learned and some challenges that we faced that needs solutions. For example, because they were in one place, we had some within the hospital setting or a facility setting, some were called to attend to other work within that time. So moving forward, if we had a similar situation, we would opt for protected time with the facilities or the leadership to make sure that the teams wouldn't move and do other activities. But also would then recommend the disk leads, instead of sending materials electronically to the other team members within the countries, to make sure that they are sharing printed versions for the sake of network challenges, because of network, some were unable to open a certain presentation and maybe they get offline, and those are the things that needs to be troubleshooted before that. But I must also say that the on-site support is always required. However, in this context, since we need to be doing it virtually, only a few that were poorly done were being visited. But as we move with other projects as well, we are learning other ways of doing virtual mentorship. So right now, we like the current other projects that we have in South Africa, we've also started an item of doing WhatsApp video. So literally using WhatsApp video to facilitate that. But at project level for the WASH project, there was also more time. You can see the timeline that I shared was 1 year, which countries had at different timelines. And if they had more time at project level, then the data that would be shared would be more, because there would be more time for them to learn and to engage. Thank you.
Maureen, I'm going to cut. Yeah, thank you. That's great. I feel like we need more time. There's so many things to dive into more deeply for this conversation. So we will find ways after this event to re-engage so we can get out more information. I know we have a lot of questions coming in from our audience too, but we have Mavis now. Thank you for being so patient. Mavis Gomcore, it's your turn to present on Ghana. The floor is yours.
Hello, thank you for the opportunity. In Ghana, we look at the quality improvement. That's improving quality of WASH services in the 5 countries, of which I'm diving into Ghana. Please, next slide. A brief introduction about what Ghana we did. We selected 25 facilities within the CHAG network, of which we provided quality and performance to healthcare environment for the facilities that were selected. Next slide, please. One will ask what CHAG did. We use our primary source data. That is, we collected data from the various facilities. Upon receiving their data, we look at it, we organize training both in person and virtual, of which we look at their infrastructures at which we are going to improve. Team members were built up to adapt the strategies that we are bringing on board for the project. Please, next slide. Achievement and successes through these strategies that were adapted. Now we have realized that most of our facilities have increased in the level of hand hygiene practices and then quality of cleaning services, as well as the infection prevention control and quality improvement teams that were acquired great knowledge and techniques that they are using now to support the facilities in trainings and also supervising staff. And also customer and staff satisfactory surveys are being done quarterly. Management involvement has also increased, and facilities have also repaired their infrastructures, as you can see in the picture by the side of the presentation. Next slide, please. Our success story. I'll put it that way because most of our facilities and staff client inspection rate has reduced drastically, especially at the maternal health unit. Below are the few exception cases that I would like to share. At Asamai IZA Hospital, they have recorded 0 maternal death in 2021 after battling with it for 3 consecutive years. At St. Gregory Hospital at Bujumbura, they have also recognized the reduction of maternal death and improved upon neonatal health. We recognize also at Pentecost Hospital in Medina that there has been a reduction in cesarean section wound infection, of which they were battling with. And we realized that at West Gonja and then Lambisi Presby hospitals, they are now having 24/7 water supply in their maternal and child health units. Please, next slide. Upon all these successes, we will not say that there weren't challenges. Funding were one of the key challenges that facility were facing, because assessing their support was one thing that usually delays. And one thing is human attitude. We're having initial resistance to change by staff due to the fact that they said that their workload is going to increase, poor attitude of staff and clients on environmental cleanliness, unreliable water supply was key, and inadequate logistics for cleaning staff to work with. Next slide, please. Sustaining all this, now we have adapted the routine maintenance culture. We are providing supportive supervision. Management commitment to all these things that I've talked about has also increased, and they have done budgetary allocations for the IPC teams. We are having also performance assessment and performance indicators that we use to assess the facilities. And we have also ensured that there is quality improvement teams that are being functional at all times, at all levels in our facilities. And the facility have tended to seek funding from their stakeholders as well. We take periodic reporting and continuously provide training services for our clients, of which they do it at the facility level. And we at the Secretariat also do refresher courses for the quality improvement teams that we formed. Next slide, please. On this, I say thank you.
Thank you very much, Mavis. Just quickly before we move on to the audience questions, and it will be like a rapid question and answer time, but Mavis, I did want to ask you, you showed in your slides a number of impressive results. What do you feel was the most significant change you saw at the Christian Health Association of Ghana and you saw in the facilities over the implementation time period that you showed us?
Thank you for the question, Sarah. We realized that quality improvement team was not functional in our various facilities. So we adapted that strategy, improve upon the teams that were not functional. They came on board. We gave them the knowledge through training, subsequent trainings, and also they welcome the idea and they put into practices. Now, if you go to most of the facilities that were selected, they have the teams that are functioning very well, and they give ideas. Some have adapted into newsletters that they share every week. For instance, at Asama SDA, they've done it every week for people to know what is going on and what they have achieved through the trainings that they are being done. Thank you.
Thank you. Thank you very much. So that was wonderful. We've all learned a lot. And like I said, we'll share out those presentations. We do have several questions in the Q&A. I also have several questions, but we'll go to the audience. And what we'll do is I'll give you 2 questions in 2 different rounds. And if we have more time, we'll get to the final few questions. And what I'm going to ask is that people don't answer every question and just keep your answers very succinct. So like 1 minute. And what I will do is I will unmute when a minute is up so that you can see that you need to wrap up. I'm sorry to do that, but this is how it goes. So the first 2 questions to choose from are, one is on if someone could speak to the issue of sexual harassment and disrespect and abuse of women during childbirth, and how you feel this impacts quality of care for maternal health and what actions are needed for improvement. So that's one question, really looking at abuse and disrespectful care in maternal health. Another question that's really interesting is the COVID-19 pandemic and resulting supply chain shocks have exposed the vulnerabilities of health systems worldwide. Given this experience, what steps are you taking to increase the resilience of health systems to future shocks, including climate change? Is there anyone who wants to jump in on either of those questions for a quick response, looking at abuse during pregnancy and delivery, and then also looking at shocks like climate change and supply chain shocks? You can just unmute if you want to jump in.
Okay.
Go ahead, Margaret.
Yes. Good afternoon, everyone, again. I'll want to respond to the question on abuse and neglect. Working from a third world country, a developing country, and going through war, some of the issues, people are not very much familiar with right-based approach and right-based service provision. So first of all, what led to women like huge underutilization of facilities and SRH services is because of neglect and abuse. Once somebody, he who feels it knows it. Once one person has come to your facility and has gone through neglect and abuse, it leaves an indelible mark. So that one person going to the community is going to tell them, when you go to that facility, you are neglected. There is so much abuse going on. And it gives people, they are afraid of the unknown. So issues countries where you have huge teenage pregnancy, it's going to make them stay at home. So it leads to the first delay for them even accepting. It leads to misconception, They are afraid of coming to the service provider even when they are available. Even when services or commodities are there, they will not come. So that has an implication in leading to unwanted pregnancy, is even on utilization of the services at the facility, and the community will not have faith. They don't have faith to come to your facilities. Amidst, we have started seeing, even with free healthcare, some facilities, they are like white elephants. Nobody is using. And when you ask the women, these are some of the issues that are coming up. So from Sierra Leone, it needs to be addressed, you know. So the experience of care matters more. So for us in quality of care, we have prioritized doing an assessment for us to know what our clients and patients are saying about our health facilities and about the services they receive. So the community scorecard that will be implemented will give us a clear, independent view of how our services are, and that can lead to proper planning in the next QED cycle.
Wonderful. Thank you so much, Margaret. Does anyone else want to jump in on that? Zoya, go ahead.
Yeah, I can comment something upon the break in supply chain during COVID. What happened during COVID, we do have online reporting, ordering systems, but then what COVID actually helped us do is to further strengthen the online ordering and reporting. So for example, there is one system which is called the FPLMIS, Family Planning Logistic Management Information System. So that was further strengthened so that we know which facility where needs what kind of family planning commodity, how much is going out, how much they need to order again. One is that. Second is the use of CoWIN. CoWIN is an online portal in which the COVID vaccination is entered and the availability of COVID vaccine across all cities in India, across all hospitals at an online time. Anybody can see where the vaccine is available, which vaccine for which age group. You just have to register and you know where the availability is. Second is this. Third, which comes to mind also is a thing which is called DVTMS. I mean, these are all acronyms, I'm so sorry. But these all, again, help the states and the government in keeping in sync with what is being ordered. And in real-time basis, they can know where the medicine is going, how much is being sent, whether it is first in, first out, whether the expiry is being used or not. So I think COVID made us realize that all these systems need to be strengthened, need to be scaled up so that everybody can use them. And it ends up giving better services and better commodities for all the people who are visiting government institutions.
Wonderful. Thank you so much. Does anyone else want to jump in on either of those, or shall I move to the next? Okay, I will move to the next.
I can talk about climate change as well. Sorry.
If you want to quickly address the climate change, that would be great.
Because climate change is something which is it's an upcoming thing. We have an institute of national importance as well, which is working on it. And just to let you know, since especially for the Adolescent Health program I'm mentioning, is that we have added it as a part of a training manual for the medical officers, for the counselors as well, so that when they do outreach activities in schools, in fact with teachers also, this topic of climate change, how can every child, every adolescent make change in their own behavior, whether it is just switching off light, turning the tap on, what to buy from market, what not to buy, small things, very easy to do, not technical, not very medical, but that is what we are trying to develop now and sharing with all the states as well. Yeah, good thing.
Wonderful, thank you. And that kind of leads us actually into another question that came from our audience that's also talking about young people. And the question is, as young people are increasingly mobile, how are providers engaging with patients to ensure follow-up visits are made, for example, for antenatal and family planning? But I would think for any of the services you've all spoken about, what additional steps need to be taken to ensure patients have continuity of care, even in their, even if their physical location changes, but how does that continuity of care lead to quality of care? So that's one kind of question for you. Another one is really trying to talk about something that was brought up even at the beginning of the event, and that's equitable and people-centered care, which we know is a high priority for quality of care stakeholders. However, we are still far from delivering people-centered and equitable care for all women, newborns, children, and adolescents. So what will it take to move the needle to reduce disparities in quality of care for marginalized populations? So one is more focused on continuity of care, and the other is really focused on working more and reducing disparities for marginalized populations. Maureen, go ahead.
I just want to respond on the disparities. I think one thing that we have worldwide is that we do have evidence-based solutions And most times we want to apply the evidence-based solutions as they are, but we need to involve the front line, the community engagement, community involvement, including the moms in the hospitals. If you think about maternal or the youth, like the example that Zoya was giving, if we engage them, if we involve them, they are the best solution makers because they know what they need. And some contexts or some settings, they are culturally driven. And if we can understand their culture and be able to align our solutions with what they need, then we win, and we want to have that. But of course, we also need universal health coverage, as you've said. Some of the countries within our setting, sub-Saharan Africa, access is a problem. We need to be taking services to the community because we don't have enough clinics or enough facilities, and we need to have mobile services that are workable, that are applicable, and also that are needed to the different communities. Thank you.
Good afternoon again. Thank you very much, Maureen. In addition to what you have said, I think the new initiative about self-care, we need to actually incorporate that into our services because we have seen what COVID has done. There are lockdowns, they will not be able to come to us. So we need to also educate them and give them information about self-care, and we need to ensure at least that we have some ICT connectivity. Now, mobile phones, even in the least village, you have it, and they have access to data. So once they are able to use that, we can use the virtual platform to send information and SMS to reach them. I think that one also can be very much helpful.
Thank you. Thank you very much, Margaret. I think we have time for just maybe one more question. And if there's an extra minute, Zoe, I'll let you come in. But this one came from Mavis. And this is really about your presentation and photos highlighted the high level of engagement of community members. So this might apply to some of the rest of you too, but I'll let Mavis kick it off. And so community members and health workers, their engagement in improving WASH readiness and services in the 25 network facilities that you've mentioned. What do you think contributed to this level of high engagement?
So thank you for the question, Sarah. I would say that we involve them in the mornings, and then whenever they come for their routine checks, education is being provided through the KY teams that I talked about. They educate them the need for them to practice the self-care practices that are being taught, of which one advantage point, we provided a hand hygiene standpoint for them to be washing their hands, and others were provided with PPEs, like the face mask. So with this, they thought that we've not left them aside. We have brought them on board. We are thinking about the staff and also the community as a whole. Other than that, everything that we're doing will be staff-based, but we extended our hands to the community as well. So when they are invited, they come on board to listen and then practice. And some of them share with their community members, of which the news was broadcast all over the communities that the quality improvement exercises was done. Thank you. Over.
Thank you very, very much, Mavis. Zoya, we're about to go to Koki for final remarks, but did you have one thing you wanted to end on? I saw you unmute. Zoya, no?
Okay, no.
Sorry, go ahead.
Yeah. Just one line which was mentioned, you talked about the mobility of adolescents. So just to add to it is that a lot of our programs are basically, since India is a highly rural country, we have a lot of villages, but a lot of our programs are funded only for the rural population. But now we are seeing there's a lot of migration, a lot of young people are moving from villages to towns, whether for education or jobs or after marriage. So now more and more of our intervention programs are now also going into the urban health also. So I'm just saying that's how I think a lot of countries are changing their program implementation, changing the targets. And yes, and that is why more and more involvement of youth in planning also, and then getting a feedback from them. That is something we should try to build into our program, so that there's a huge, we had adolescent health poll, then we have interaction with the adolescent bodies also. Something you cannot work for a program for adolescent and youth without actually involving them. But I think we are taking baby steps and hopefully we should be there. That's it.
Thank you. That's great, Zoya, and thank you all. I know Blerger and Patricia, you stayed on and there's not enough time for more questions and answers, but I really do appreciate everyone being here today. And we will follow up because there's definitely a lot more coming in from our audience and questions that people have. So we'll have future engagement on that. But for now, to provide some closing remarks and comments is Dr. Kofi Agwal, who is the project director of USAID's Momentum Country and Global Leadership Program and vice president of DC operations for JPIGO. Dr. Agwal is an internationally recognized expert in safe motherhood, reproductive health, and family planning policies and programs, and has more than 25 years of service delivery experience in reproductive health, family planning, and maternal health. Turning it over to you, Kofi.
Thank you so much, Sarah, and to the Wilson Center's Maternal Health Initiative for this partnership. And thank you today to all the presenters and panelists who shared their expertise and perspectives with us today. You know, the COVID-19 pandemic has challenged health systems all over the world in the ways that we could not have even imagined just 2 years ago. Lockdowns, the fear of seeking care, service interruptions, and economic hardships have disrupted essential healthcare services. We know that these challenges then stacked on top of the barriers that vulnerable women, newborn children, and adolescents in low and middle income countries already faced in accessing quality health services. Thanks to Blerger and Patty for sharing their perspectives on the importance of quality healthcare service. We are convinced that women and children need quality healthcare to survive and thrive. And that urgent need is exactly why the country perspectives shared today are so critical. Countries are leading the way to identify approaches to improve quality at all levels of the health system to reach women, newborn children, adolescent, and youth with respectful and person-centered care. Dr. Zoya Ali Rizvi shared how India is taking a multi-pronged approach to improving the quality of youth-friendly family planning, reproductive health care in India, taking their work from facilities to schools and into communities themselves, and ensuring that the services are driven by the youth themselves. In Sierra Leone, Matron Mana and detailed how an integrated roadmap paired with strong political will and Ministry of Health leadership is truly making a difference to improve both quality and availability of essential MNCH services, family planning, and reproductive health care. And our colleagues, Maureen and Mavis, showed how comprehensive quality improvement support can make a real difference in how people receive care at the facility level. 2 years into an ever-evolving pandemic, and we have no time to lose when it comes to learning from these examples. USAID's Momentum Country and Global Leadership is committing to facilitate such cross-country and global learning dialogues and what is sharing what is working when it comes to maintaining essential health services in a pandemic. Our Momentum team works with and through local entities in everything we do, including ministries of health, non-government organizations, the private sector, and civil society and faith-based organizations and community. And quality is at the core of the work. At the end of the day, we recognize that we cannot accelerate reductions in maternal, newborn, and child mortality and morbidity in USAID partner countries without quality. In other words, there is no progress without quality. So thank you today for taking the time to join this discussion. We hope you'll continue to share what is working in your country to improve quality of care, to improve maternal, newborn, and child health services and family planning outcomes. Thank you so much.
Thank you, Kofi. And thank you so much again to the Momentum team for all your work putting this event together and also for the great partnership we have with the Maternal Health Initiative and creating this series so that we could hear everyone's experiences today, because it was just incredible. Thank you all for being here. This event was recorded and we will have the recording up and we will share it with you, everyone in the audience and everyone here. Within the next day. We will also do an event summary and publish that, which we will also share with you. So my final thank you to our audience for being here today and sending in such great questions. And with that, I wish you all a great rest of your day. Thank you.